This week is going to be all about acute myocardial infarctions, or STEMIs, and then we'll talk about acute coronary syndromes and non-STEMIs. And I know you're like, oh my gosh, like this is the only reason why I'm taking this class is to talk about STEMIs and heart attacks and myocardial infarctions. Why do we talk about all this stupid crap in between? But hopefully it'll all come together. STEMIs and ST elevation MIs and myocardial infarctions have a lot of imitators. So as we go through these STEMIs and different myocardial infarctions, hopefully we'll be able to pick apart those imitators. So you can, when you actually call a code STEMI, you're actually calling a code STEMI and not really just pissing off the cath lab team. First thing we need to discuss is that there is a continuum. There is a gradient of injury, is a gradient of infarct. So we start up at the top. That's our normal state. And we've got this cardiac muscle. And in this normal state, our heart, our cardiac muscle, is getting the oxygen supply that it needs to meet its demand. So once we get down into ischemia, into injury, we don't have enough oxygen to meet the demand of our cardiac muscle. So in ischemia and injury, our oxygen needs are not met by our oxygen supply, and or maybe there's an increase in demand or a decrease in supply. So oxygen needs not met by supply, demand not met by supply. Could be an increase in demand, and it's not a supply issue, or it could be a decrease in supply and it's not a demand issue. So we go from our normal state into ischemia, then we start getting some actual cardiac injury, some actual muscle injury, and then we go into infarction if we continue on down that continuum. What supplies our oxygen for that demand is our circulation. So if we think of our cardiac circulation, these cardiac arteries, right? Um, think of it as a kind of a tree-like structure. We've got a main trunk, we've got a big old trunk. Think of that as your aorta. And then that big old trunk divides into large branches. Those are your coronary arteries. And then those large branches divide further into like kind of still a little big branches, right? But smaller branches, and then those smaller branches end in these like little twigs and these leaves, right? So we've got this big old branch that divides into kind of smaller but still big branches, and then those divide into kind of smaller branches, and those divide into these little twigs and leaves, and that's what's supplying our heart with blood and our oxygen supply. And we know about our coronary arteries, but there are also a few like kind of cool little protective mechanisms that our heart has. Remember, your cardiac muscle, your heart, is going to feed itself first with oxygenated blood, and there are some protective mechanisms here. The first is this collateral circulation, where all those branches, if you look up into the forest, you're going to see different trees, but the branches kind of overlap a little bit as they get up into the canopy, and that's collateral circulation. So we've got areas of our heart that are supplied by a couple different branches. So we've got kind of got this overlap. So if one tree dies or isn't able to deliver that oxygen, that blood, well, we still have a little bit of supply coming in from that other tree, that other branch. So that's collateral circulation. Another one is oxygen can actually diffuse directly into some of these surrounding cells from the ventricles themselves. So we have a little bit of oxygen diffusion around the ventricles themselves. And then we also have Thebesian veins. And these Thebesian veins, which is kind of a fun word to say, come directly from the ventricles and kind of feed little areas around the ventricles themselves. So there are these like little tiny, teeny tiny coronary veins that feed the ventricles, kind of this area directly around the ventricles themselves. So if we have some problem with supply with that oxygen supply, that blood flow, the Bayesian veins can kind of help mitigate that a little bit, and so can this oxygen diffusion from our ventricle. So collateral circulation, we said think of a bunch of trees in the forest. If you look up, we've got some branches kind of overlapping each other. So we've got these main trunks here at the top, and they kind of branch off, branch off, branch off. But then we've got these areas of overlap. So if I have a clot right up here, I still have some blood flow down here, so my area of infarct, my area of injury isn't going to be as great as it might be without that collateral circulation. We also talked about a little bit of oxygen diffusion from the ventricles themselves, so you might have a little bit of diffusion kind of into little areas of the ventricles themselves. And then we have these little tiny Bayesian veins that kind of go a little bit deeper than that diffusion will go to kind of provide a little bit of oxygen supply to our heart muscle. Just in case this big old coronary artery is blocked off. If we do block off this coronary artery, we've got areas of ischemia, injury, and infarct, which we're going to dig into a little bit deeper here coming up. But this coronary artery is compromised, we still have these kind of compensatory mechanisms to provide our cardiac muscle with just a little bit of oxygen supply. So we've got this continuum, right, of ischemia to injury to infarct. So let's kind of define these three things. First is our ischemia, and this is where our cardiac muscle needs oxygen, so it's demanding oxygen, but the supply isn't quite meeting that demand. So we've got a little area, we're starting to see some ischemia. We've got an area that's more negative than the surrounding tissues, so we've got this ST segment depression. We might have a flipped T wave, but definitely if we see ST segment depression, we've got ischemia, and this is because repolarization is not happening along its normal pathway. So in ischemia, this is the very beginning of this continuum, of this gradient, and we've got this supply and demand issue where our heart isn't really being supplied with 100% of the oxygen that is demanded. We continue on this continuum from ischemia. Now we've got injury. So we've gone beyond ischemia into injury. We're still going to have some zones of ischemia around the zone of injury itself, but the zone of injury is not going to repolarize completely, and that's going to do some funky things to the ST segment, do some funky things to the T wave. So usually in injury, we'll see a flip T wave and ST segment elevation. So when we are saying, oh, my patient's having a heart attack, I've got a STEMI, I've got an ST elevation MI, hopefully we are catching it in the area of injury where it's still reversible. So in injury, it is reversible. It's not those cells are not completely dead. We've got an area of injury, and if we catch it early enough, that ST elevation, we can prevent permanent damage to the heart. But if we wait too long, we end up in complete infarction, and this is just dead tissue. And your cardiac cells do not regenerate. If a part of your heart dies, those cells dies, they are dead. So here again, you might see ST elevation, might see a flip T wave, but here's when we get into that Q wave that we talked about earlier on. And we have that Q wave because now this infarcted area that we see in black is this like open window. There's like a window in a window. And we see this Q wave because in the electrode in which I am looking through, that's my window. Imagine if you're looking into a house, into the living room from the outside. You're looking into the window, the outside window, into the living room. But imagine if that living room wall on the other side had another window into the bedroom. So what you're actually saying is the bedroom. So we were adding another window that shouldn't actually be there. So that's where the Q wave comes from. The infarction is dead tissue that's not coming back, and that is permanent damage. That's why we say with these significant pathologic Q waves, something happened long ago. Even if your patient says, "Nope, I am 100% healthy." Nope, something happened because you have a Q wave, you have a pathologic Q wave. There is like a window within a window in your heart, and that's bad. These infarctions, these clots. So an infarction, is just a clot in your coronary artery. These issues are just clots in your coronary arteries. They can happen upstream, they can happen downstream, they can happen big in one of those big main trunks, or they can happen, a little bit smaller in one of those little smaller little offshoot branches. So that's going to determine the area in which is affected. So if I'm super upstream, I've got infarct number 4 up here. That's going to affect this entire area. But if I am a little tinier clot way downstream, it's just going to affect this little tinier area. So if we're talking, yeah, once you go to the cath lab and see these images, where is the clot in that coronary artery or within that branch of the branch of the branch? Based on how upstream or downstream that clot is, these are going to produce these transmural or non-transmural infarctions. So if we are way, way upstream, super thick branch, right, we're going to have this transmural infarction. And what we're going to call this is this full thickness infarct. So if we think of these like burns, we have a full thickness burn. It goes all the way through. Our transmural infarctions are going to go all the way through the epicardium. All the way through. And these are the ones that are going to cause Q waves. So if you see pathologic significant Q waves on your patient's 12 lead, they had a transmural, a full thickness, we'll say, infarct, a pretty big infarct. Our non-transmural, these aren't going to produce Q waves. These are a little partial thickness, so you're like first degree, second degree burns. Partial thickness infarcts, and they're not going to go all the way through. So our transmural infarct is going to go all the way through our epicardium there. And infarct, all of this are non-transmural or partial thickness infarcts, just a little bit right there. So our transmural, the ones that go all the way through, are going to produce Q waves, pathologic Q waves, and our non-transmural ones will not produce those pathologic Q waves. What does this all look like on our 12 lead? Well, we start with our normal state. We go down into ischemia as supply does not equal demand, and then into injury as supply demand decreases even more and supply goes up, and then into infarction where we have cell death and irreversible cell death. Well, our normal state, we've got a nice, look at that, ST segment is baseline, nice upright T wave. As we get into ischemia, we're going to go into some ST segment depression, into ST segment elevation with a flipped T wave, into injury. We're starting to see this Q wave develop. So if we keep hitting that 12 lead button over and 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 over again on our patient with chest pain, we might see this progression. And this is how this progression goes. So if we see ST segment elevation, hopefully we're catching it in the injury stage and not the infarction stage. So in the injury stage, we can save cardiac muscle. In the infarction stage, we already have dead cardiac muscle. Now, when talking ST segment elevation and ST segment depression, we might see reciprocal changes. And we're going to kind of differ these from ischemia by saying this is a mirror image of two views, two windows that look from different sides of the heart, different sides of that house. So we're going to have ST segment elevation in one lead, but we're going to have ST segment depression in another lead, in that reciprocal lead, because it's in the opposite side of the heart. So I've got ST segment elevation over here because I'm looking this way, and then my opposite window looking this way is going to see, well, that's ST segment depression. So I've got elevation in one area, I've got depression in another area, and those are what we're going to call uh, reciprocal changes. But reciprocal changes don't happen just like anywhere, right? Maybe I'm looking at like V3, and like we're going to have a reciprocal change in like lead 2. Nope. Um, so where our reciprocal changes are going to happen, leads 2, 3, and AVF. So I've got 2, 3, and AVF down here, and 1 and AVL up here. So they're kind of opposite each other. So we're going to see reciprocal changes in those. If I have ST segment elevation in 2, 3 AVF, I'm probably going to have ST segment depression in 1 in AVL. And um, and the opposite is also true. So maybe I have ST elevation in 1 in AVL. I'm going to have ST segment depression in 2, 3 AVF. Our other reciprocal leads are going to be V1, V2, right there, and V7, V8, V9, which are our posterior leads. So maybe I have elevation V1, V2 if I look posteriorly, which isn't on this diagram. If I have elevation V1, V2, I'm going to have depression in V7, V8, V9, our posterior leads. And the opposite is also true. If I have ST segment depression in V1, V2, that's an automatic cue for me to do a posterior 12 lead, V7, V8, V9, remember? So I might see elevation in V7, V8, V9. So those are our reciprocal leads that we need to pay attention to. So our 2, 3 AVF, reciprocal to 1 in AVL, and V1, V2, reciprocal to V7, V8, V9, our posterior leads. Well, that all bears discussion on what region am I looking at through all of these windows. I've got 12 windows. What part of the heart am I looking at? So, 2, 3 AVF, inferior. That's the inferior portion of your heart. V1, V2 is your septal region of the heart. V3, V4, your anterior region. V5, V6 is your lateral. And then we're going to scoop back around to lead 1 and AVL. Those are also lateral, but those are higher lateral views. So V5, V6 are lateral, but don't forget to look at lead 1, which is also lateral, and AVL, also lateral. And these lead 1, lead AVL are kind of these higher lateral, but still looking at the lateral wall of the left ventricle. AVR we're not going to worry about for right now. And then we obviously know V7, V8, V9 are our posterior leads. We know we can flip over V4, V5, V6 onto the right side and get a right-sided view. But for our typical 12 lead, here is the regional layout for you. So if we say, where do you see ST segment elevation? If you see it in 2, 3 AVF, well, that's an inferior MI, right? Because it's the inferior region of the heart that we're looking at. And thinking a little bit further, so we've got a region in which we have some injuries, some ischemia, some infarct. Well, what coronary artery is involved with that region? So if we look in that inferior region, usually the RCA, the right coronary artery, for most people. Sometimes it's the left circumflex, the LCX, left circumflex, but our inferior, usually the right coronary artery, the RCA, And that's why we always do a right-sided 12 lead when you see an inferior STEMI, right? We're always going to do a right-sided. Our anterior going to anterior septal, into anterior lateral, left anterior descending artery, and then going into kind of like our posterior inferior laterals, maybe a little bit of our left circumflex. This is all patient specific because we all have different anatomies, but typically, so here for you visual people, you know, inferior typically RCA. If we're going septal V1 V2 or anterior V3 V4, usually left anterior descending. If we're talking lateral V5 V6, 1 in AVL, typically left circumflex. We're not going to talk about AVR quite yet. We'll get into that a little bit later. But just here's a different kind of visual for you. And for most people, typically, kind of typical anatomy, here are the arteries that are involved with these different regions.